So, dear organizing committee, dear ladies and gentlemen, thank you for inviting me to this talk about immunotherapy and gene cell therapy in sarcoma. Immunotherapy already has a long history. In 1980, William Coley, a surgeon, was able to induce tumor shrinkage by inoculating specific bacteria into the tumors. This vaccine was later named after him and was called Coley's toxin. 1999, Paul Ehrlich developed the hypothesis that the immune system is able to detect and defeat diseases and cancer cells, and won the Nobel Prize for his discovery. In the early 50s, Burnett and Thomas postulated the hypothesis that immune cells are monitoring the body to identify cancer cells and destroy them. 30 years later, a bacteria called Bacille calmette-guerin was used for the first time to treat bladder cancer by causing a local immune reaction in the bladder. In 1986, interferon alpha was approved for the treatment of hair cell leukemia. 10 years later, immune checkpoints were identified as regulators of T cell activity. 1998, interleukin-2 was approved for the treatment of metastatic renal cell carcinoma and malignant melanoma. About 10 years later, ipilimumab, an antibody that inhibits the CTLA-4 receptor, was the first checkpoint inhibitor to be approved for the treatment of metastatic melanoma. Since then, the role of immune system in the fight against cancer is still an important subject of intense research. There are two types of immunity, the innate immunity and the adaptive immunity. The innate immunity is inborn and the first reaction of the immune system against intruders. It reacts inspecific and quick. The adaptive immunity steps in when the innate immunity does not succeed in eliminating the intruder. The adaptive immunity specifically targets the pathogen or malignant cells. It needs longer, but reacts more specific and potent. Furthermore, the adaptive immunity develops a memory, which means that in case of the contact with the same pathogen, it reacts faster. Mast cells, dendritic cells, macrophages, natural killer cells, and different types of granulocytes are part of the innate immunity, whereas B cells, which produce antibodies, and T cells, which can differentiate to T cells with CD4 surface markers and T cells with CD8 surface markers, are part of the adaptive immunity system. The T cells can be compared to a policeman that is patrolling the environment. The immune system has the ability,
Hallo Alex.
Has the ability to detect cancer cells and
Ganz
destroy
gut.
them.
Du sag mal, hörst du Stimmen im Hintergrund?
Hello?
Gary's gone.
Okay, thank you, sorry. Going into detail, the reaction of the immune system against tumor cells can be easily explained by the so-called cancer immune cycle. This cycle can be divided into 7 major steps, starting with the release of antigens from the cancer cell. The second step is cancer antigen representation. For this purpose, so-called antigen-presenting cells use the major histocompatibility complex molecules. The next step comprises of priming and activation of T cells. The fourth step is the trafficking of T cells to the tumors. The next one is the infiltration of T cells into tumors. The sixth step is the recognition of cancer cells by T cells. In this step, the T cells detect these antigens by the tumor cell receptors and initiate an anti-tumor reaction against the tumor. And the last cycle step is the killing of cancer cells. There are many factors which play a role in cancer cell immunity, represent a broad range of potential therapeutic targets. Here you can see some examples for such treatment options. Some of them are already established in cancer treatment, such as chemotherapy, radiation therapy, and targeted therapies, which promote the release of cancer cell antigens or agents, which are actually being investigated in preclinical or clinical studies. These highlights include vaccines, which support the second step of the cancer immunity cycle, the cancer antigen presentation. Anti-CTLA-4 antibodies, which promote the priming and activation of T cells. Adaptive T cell therapy with T cell receptors and chimeric antigen receptors, the CARs, which influence the recognition of cancer cells by T cells. And anti-PD-L1 and anti-PD-1 antibodies, which facilitate the killing of cancer cells. The VEGF inhibitors enable T-cell infiltration into the tumor. On the next few slides, I will show you the reaction of the immune system to tumor cells. Here you can see the occurrence of a tumor cell between healthy cells. The T cells are usually controlling the cells in the body. And they are able to detect tumor cells. And finally, destroy them. The cancer immunoediting is an extrinsic tumor suppressor mechanism that engages only after cellular transformation has occurred and intrinsic tumor suppressor mechanisms have failed. The cancer immunoediting consists of three sequential phases: the elimination, equilibrium, and escape. In the elimination phase, innate and adaptive immunity works together to destroy developing tumors long before they become clinically apparent. In this phase, if this phase goes to completion, then the host remains free of cancer. If, however, a rare cancer cell variant is not destroyed in this phase, it may then enter the equilibrium phase, in which its progression is prevented by immunologic mechanisms. T cells are required to maintain tumor cells in a state of functional dormancy, which indicates that equilibrium is a function of adaptive immunity. Editing of tumor immunogenicity occurs in the equilibrium phase. Equilibrium can also represent an end stage of the cancer immunoediting process and may restrain outgrowth of occult tumor cells for lifetime of the host. However, as a consequence of constant immune selection pressure placed on genetically unstable tumor cells held in equilibrium, tumor cell variants may emerge that are no longer recognized by adaptive immunity and become insensitive to immune effector mechanisms or induce an immunosuppressive state within the tumor microenvironment. These tumor cells may then enter the escape phase, in which their outgrowth is no longer blocked by immunity. These tumor cells emerge to cause clinically apparent disease. But how can tumor cells survive the anti-tumor response and enter the escape phase? Tumors can develop various mechanisms to escape their identification and destruction by the immune system. These mechanisms are reduced expression of MHC molecules or suppression of antigen-presenting cell function, secretion of immune-suppressive cytokines and mediators in the tumor microenvironment that suppresses the function of T cells and other immune cells, and the recruitment of immunosuppressive cells in the tumor microenvironment, which inhibits the activity of the immune system, like regulatory T cells and myeloid suppressor cells. Another mechanism of immune invasion is the ability of cancer cells to harness T cells' immune tolerance pathways. The T cell activity is modulated by co-stimulatory and co-inhibitory receptors which are active in healthy hosts to restrain the immune reaction, to prevent tissue damage, and are the main factors responsible for immune invasion. These mechanisms can suppress the anti-tumor immune response and facilitate tumor escape. PD-1 pathway inhibits the tumor-specific immune response. Tumor cells can develop defense mechanisms and are able to mislead the immune cells. The inhibition of the immune system can be reversed by immune checkpoint inhibitors. And due to the immune checkpoint inhibitors, immune cells cannot be misled anymore. And they are again able to recognize tumor cells. The immune treatment in the strict sense involves adaptive T-cell therapy and immune checkpoint inhibitors. Immunotherapeutic strategies enhance different components of the immune system. The adaptive T-cell therapy uses populations of cytotoxic T-cells which are extracted from the patient, then are ex vivo genetically manipulated and are being reinfused to the patient. The immune checkpoint inhibitors remove the blockage like CTLA-4 or PD-1 on the T cells to maintain their activated status and their cytotoxic function. And these are the currently available immune checkpoint inhibitors and their targets, CTLA-4, PD-1, and PD-L1. And these include ipilimumab, tremelimumab, nivolumab, pembrolizumab, avelumab, durvalumab, and adesolizumab. Immune checkpoint inhibitors can be administered in the following cancer types: Hodgkin lymphoma, non-Hodgkin lymphoma, liver cancer, kidney cancer, cervical cancer, in melanoma, head and neck cancer, solid tumors that are microsatellite instability high or mismatch repair deficient, in lung cancer, gastric cancer, colorectal cancer, bladder cancer, and Merkel cell carcinoma, which is a specific subtype of skin cancer. Immune checkpoint inhibitors can be administered as first-line treatment, which means as first therapy in metastatic lung cancer with high PD-L1 expression, in the second-line treatment, which means after progression of the first-line treatment and after chemotherapy, and as a combination with chemotherapy. Immune checkpoint inhibitors are also approved as standard treatment in metastatic melanoma and in the adjuvant setting, which means after surgery, when the patient has no evidence of cancer. Additionally, immune checkpoint inhibitors can also be administered in patients with malignant head and neck tumors with squamous differentiation and are approved as first-line treatment in patients with high PD-L1 expression and after disease progression in patients receiving chemotherapy. In renal cell carcinoma, immune checkpoint inhibitors are recommended in first or second line setting in specific histologic subtypes and are also approved as combination treatment with a tyrosine kinase inhibitor. In bladder cancer, immune checkpoint inhibitors can be administered as first or second line treatment depending on general condition, renal function, cardiac function, and the biomarkers. Immune checkpoint inhibitors can also be used in colorectal cancer with a specific biomarker, the macrosatellite instability high, which occurs in about 15% of those patients, and also in breast cancer patients that are triple negative, which means that their tumors show no expression of hormone receptors or HER2 receptor, and which show a PD-L1 expression. In these breast cancer patients, the treatment can be also combined with chemotherapy. The most common adverse events after immune checkpoint inhibitors are due to an immune reaction to an autoimmune reaction based on an overacting immune system. They can affect all organs and are usually not severe. Possible symptoms are cough, diarrhea, rash, and hyper and hypoactivity of the thyroid gland. Adverse events can occur at the beginning of the treatment or at the end of the treatment with immune checkpoint inhibitors. The management of adverse events depends on the degree of the severity. First, the immune checkpoint inhibitors has to be stopped. Then the patients are usually treated with cortisone and sometimes also receive a local treatment, for example, when they have a rash. In certain cases, additional specific treatment is needed. In the following part of my talk, I will show you some studies which were conducted to evaluate the efficacy and the safety of cancer treatment with immune checkpoint inhibitors and adaptive T-cell therapy. To understand the assessment of the response to these therapies, one has to understand the radiologic response criteria. According to the RECIST criteria, which are most commonly used, complete remission means a disappearance of all lesions. Partial remission is a 30% decrease in the sum of the longest diameter of the lesions. Stable disease is neither partial remission nor progressive disease. And progressive disease means a 20% increase in the sum of the longest diameter of the lesions or occurrence of new lesions. According to the CHOI criteria, most commonly used for the evaluation of tumor response to targeted therapies, complete remission also means the disappearance of all lesions. Partial remission means a more than 10% decrease in tumor size or 15% decrease in tumor density. Stable disease is neither partial remission nor progressive disease. And a progressive disease means a more than 10% increase in the sum of the longest diameters of lesions or a 15% increase in tumor density or occurrence of new lesions or new intratumoral nodules, or an increase in the size of the existing intratumoral nodules. The first immune checkpoint inhibitor study was the SARC-028. 84 patients with soft tissue sarcomas and bone sarcomas were included in the study and received pembrolizumab, an anti-PD-L1 antibody, every 3 weeks. And here you can see the waterfall plot of the patients' responses. These are the patients that responded, and these are the non-responders. Every patient is represented by his own bar. Patients with undifferentiated pleomorphic sarcoma, liposarcoma, synovial sarcoma, and leiomyosarcomas were included in the study. In the 40 patients with soft tissue sarcomas, 1 patient showed a complete remission, which means he had no evidence of tumor. 6 patients showed a tumor decrease, a so-called partial remission. 15 patients had a stable disease. The responding histologic subtypes were undifferentiated pleomorphic sarcomas and dedifferentiated liposarcomas. In the 40 patients with bone sarcomas, only 2 patients showed a partial remission and 9 patients had a stable disease. Patients with chondrosarcoma, Ewing sarcoma, and osteosarcoma were included in this study. The most common adverse events after immune checkpoint inhibitors are, as already mentioned, due to the autoimmune reactions based on an overacting immune system. These are endocrine adverse events such as a loss of the adrenal gland function called adrenal insufficiency, which is a condition that occurs when the adrenal glands do not produce enough of certain hormones, including cortisol. Disruption of these hormones can cause a range of symptoms, including chronic fatigue, muscle weakness, and abdominal pain. Further adverse events are intestinal nephritis characterized by swelling in between the kidney tubules and diagnosed by high protein levels in the urine, pneumonitis, and non-infectious lung inflammation, which can cause cough and specific changes in the CT scan. But also infectious pneumonia, bone pain, pulmonary embolism have been reported. In the next immune checkpoint inhibitor study, 2 different immune treatment agents were combined: nivolumab, an anti-PD-L1 antibody, and ipilimumab, an anti-TCLA4 antibody. 85 patients with difference of tissue sarcoma subtypes were included in this study. One treatment group received nivolumab and ipilimumab. The other group was administered nivolumab only. 38 patients were included in each arm of the study. In the group with both immune checkpoint inhibitors, 2 patients had a complete remission and 4 patients showed a partial remission. In the monotherapy group, only 2 patients showed a partial remission. And these are the survival curves. You can see an increased survival in the patient group that received nivolumab and ipilimumab regarding progression-free survival and also alveolar survival. And this is the response duration, showing longer responses in the group where the 2 agents were combined compared to the monotherapy group. The most common adverse events in this therapy group, especially in the combined therapy group, were endocrine adverse events such as adrenal insufficiency, hypofunction of the thyroid gland, colitis with diarrhea and abdominal pain, nausea, vomiting, rash, pneumonitis and breathlessness and cough, nephritis, myositis, which is an inflammation of the muscles with muscle pain, neuropathy, a nerve problem that causes pain, numbness, or tingling in different parts of the body, mostly in hands and feet, fever, and mucositis, which is a painless inflammation and ulceration of the mucosal membranes. In the following study, immune treatment with pembrolizumab was combined with a tyrosine kinase inhibitor called axitinib. The rationale for this study was the hypothesis that the inhibition of angiogenesis, which is a process through which new blood vessels are formed, increases the efficacy of immune-based cancer treatment. 33 patients were recruited in this study. Axitinib was administered continuously. Pembrolizumab was administered every 3 weeks. The histologic subtypes included alveolar soft part sarcomas, undifferentiated pleomorphic sarcomas, leiomyosarcomas, and liposarcomas. And this is the waterfall plot of the patient's responses to the treatment. There were no complete remissions, but 25% of the patients showed a partial remission and 28% showed a stable disease. The patients with alveolar soft part sarcomas showed the highest benefit rate. 12 patients with alveolar soft part sarcomas were included in the study, of which 6 showed a partial remission and 2 had a stable disease. The red curve shows the survival of the alveolar soft part sarcoma patients, in contrast to the blue curve, which shows the survival of patients with other histological subtypes. And this is again the duration of the response. The blue arrows here show the response duration for the patients with alveolar soft part sarcomas. The most common adverse events in this study included fatigue, a severe form of tiredness, hypo and hyperfunction of the thyroid gland, diarrhea, nausea, vomiting, abdominal pain, arthritis and myositis with pain in muscles and joints, mucositis, palmar-plantar, erythrodysphagia syndrome that can cause redness, swelling and blistering on the palms of the hands and soles of the feet, and hypertension, weight loss, rash, and autoimmune disorders. In the Immunotherapy study, which was presented at the CITOS meeting last year, 50 recruited persons with different histological subtypes received first the tyrosine kinase inhibitor sunitinib and then a combination treatment of sunitinib and nivolumab. The response assessment according to RECIST criteria showed a complete remission in 2% of patients and a partial remission in only 9% of patients. 61% of the patients had a stable disease. The responding histological subtypes were angiosarcoma, extraskeletal myxoid chondrosarcoma, synovial sarcoma, and alveolar soft part sarcoma. However, when the Choi criteria were applied, in 1 of 46 patients, we had a complete remission. In 23%, we had a partial remission, and 9 patients showed a stable disease. Responses were observed in all histological subtypes. And this is the duration in the duration of response in the different histological subtypes. In this study, the most common adverse events were fatigue, diarrhea, also nausea, vomiting, arthralgia, myalgia, mucositis, hypertension, skin or hair hypopigmentation, weight loss, rash, and neutropenia, thrombocytopenia, and anemia. In the next study, only patients with alveolar soft part sarcomas were recruited and were administered 1,200 milligram atezolizumab every 3 weeks. Out of 34 patients, 3% showed a complete remission, 27% had a partial remission, and 50% showed a stable disease. Median time to partial remission was 4.5 months. The duration of response was more than 15 months in 50% of patients. The most common events here occurred in the study were fatigue, diarrhea, nausea, vomiting, arthralgia, myalgia, fever, pruritus, which is an unpleasant sensation of the skin that provokes the urge to scratch, rash, decrease of white blood cell count, anemia, and pain in the extremity. In another study, 30 patients with different sarcoma subtypes received an immune checkpoint inhibitor, pembrolizumab, and a chemotherapy with doxorubicin. Nearly 40% of patients showed a complete remission or a partial remission. The following study, which has been presented at the ASCO meeting last year, had the preoperative, also called neoadjuvant approach. 40 patients with undifferentiated pleomorphic sarcoma or dedifferentiated liposarcoma were administered nivolumab with or without ipilimumab. Additionally, patients with undifferentiated pleomorphic sarcoma received preoperative radiation therapy. In this study, a significant pathologic response, which was assessed by percent of hyalinization and necrosis, highlighted with blue and green bars in the surgical specimen after treatment, and means no viable tumor, could be demonstrated for patients with undifferentiated pleomorphic sarcoma, showing a median hyalinization of 93%. In dedifferentiated liposarcoma, the median hyalinization was only 8.75%. Additionally, undifferentiated pleomorphic sarcoma patients showed only a minimal residual viable tumor of 5%, highlighted with red bars. In dedifferentiated liposarcomas, the residual viable tumor accounted for approximately 80%. And this is a waterfall plot diagram for radiologic response according to the RECIST criteria. And here you can see a better response for undifferentiated pleomorphic sarcoma highlighted with green bars. There was no correlation between radiologic or pathologic response in the study, which means the destruction of the tumor in the surgical specimen. The most common adverse events were diarrhea, renal failure, elevated white blood cell count, rash, and the hyperfunction of the thyroid gland. In the TRAMOON study, which was presented at the last ESMO meeting, immune checkpoint inhibitor treatment with durvalumab was combined with trabectedin, a well-established chemotherapy in sarcoma. 3 different dosages of trabectedin were evaluated in this study, with 1 milligram per square meter, 1.2 milligram per square meter, and 1.5 milligram per square meter, and were investigated in patients with different soft tissue sarcoma subtypes, such as dedifferentiated liposarcomas, undifferentiated pleomorphic sarcomas, and others, and also in patients with ovarian cancer. 9 patients were included in the dose escalation phase, and 16 of tissue sarcoma patients and 15 patients with ovarian cancer were included in the expansion cohorts. 1 of 14 patients showed a partial remission, and a stable disease was observed in 8 of 14 patients. Tumor shrinkage was seen in 6 patients. The optimal trabectedin dose was chosen with 1.2 milligram per square meter, and durvalumab was administered with 1,120 milligram every 3 weeks. The most common adverse events in this study were fatigue, nausea, decreased white blood cell count, myalgia, infections, cardiac failure, rash, and renal failure. In the next study presented by Jean-Yves Blay at the last ESMO meeting, 81 patients with rare soft tissue sarcoma subtypes such as chordoma, alveolar soft part sarcoma, desmoplastic round cell tumors, SMARCA4 malignant rhabdoid tumors, and 32 other sarcomas received the immune checkpoint inhibitor pembrolizumab every 3 weeks. There were no complete remissions in the study, but according to RECIST criteria, partial remissions were seen in 50% of the patients. The following subtypes showed a partial remission: SMARCA4 malignant rhabdoid tumors, epithelioid sarcoma, chordoma, and alveolar soft part sarcoma. In the last checkpoint immunity study, I am going to present here the OSCAR study that was presented last year at the CIDOS meeting. 11 patients with advanced clear cell sarcoma and 14 patients with alveolar soft part sarcoma, both subtypes which are chemotherapy resistant, were administered nivolumab every 2 weeks. However, the fusions that are specific for the diagnosis of these tumors were proved in only 50% of the patients. The partial response rate was quite low and was seen in only 1 out of 25 patients with alveolar soft part sarcoma. Stable diseases were observed in 15 patients. And here you can see a summary table of the studies I have presented before, highlighting the very good responses that were observed in alveolar soft part sarcomas in the study where axitinib and pembrolizumab were combined. And the combination of pembrolizumab with doxorubicin, where promising results were seen in various soft tissue sarcoma subtypes. Now we come to the T-cell anti-tumor therapies. There are several clinical techniques that have been utilized to harness the immune system to treat cancer. In some instances, T cells are isolated from the peripheral blood of the patient and genetically transduced to express a chimeric antigen receptor, the CAR, or the T cell receptor, TCR, that confers the ability to specifically recognize and destroy tumor cells when reinfused into the patient. Another technique is the adaptive transfer of anti-tumor T cells that were isolated from within a patient's tumor. Tumor-specific T cells are extracted from resected tumor samples, then expanded in vitro, followed by reinfusion into the patient and administration of the T cell growth factor interleukin-2. The T cell receptor is a protein complex that is anchored on the surface of T cells, like for example the NY-ESO1 and ADP-A2M4, and are responsible for the detection of processed peptides which are presented on the cell surface as antigens by MHC molecules. The binding of such an antigen results in T cell activation. Such T cells are also called SPARE T cells. NI-WESO1 and MAGA4 are human tumor antigens which belong to the testis tumor antigen family. They occur in tumors such as synovial sarcomas and represent a target antigen in the development of tumor immune therapies with adaptive cell transfer. Lymphodepletion with fludarabine and cyclophosphamide is an essential precondition for the administration of adaptive cell transfer treatment. This is the study design of a dose escalation and expansion trial that assessed the safety and efficacy of ADP-A2M4 in advanced solid tumors, including the following steps: screening of patients, manufacturing of spare T cells, lymphodepletion, spare T cell infusion, and assessment of safety and efficacy of the treatment. The treatment responses were seen in different types, such as synovial sarcomas, head and neck carcinomas, and also in lung cancer. In the subgroup analysis for synovial sarcomas, 44% of patients showed a partial remission with a median duration of response of 28 weeks. The most common adverse events in this study were pancytopenia, which is a decreased white and red cell blood count and decreased thrombocytes, fatigue, nausea, vomiting, fever, cytokine release syndrome, which is caused by a large rapid release of cytokines into the blood from immune cells. Cytokines are immune substances that have many different actions in the body. Signs and symptoms of cytokine release syndrome include fever, nausea, headache, rash, rapid heartbeat, and a low blood pressure, and also trouble with breathing. Further possible adverse events were diarrhea, decreased appetite, dyspnea, tightening of the chest with air hunger and difficulty with breathing, and hypotension, a low blood pressure. The previous study laid the foundation for the initiation of the SPAREHEAD-1 study, a phase 2 study of ADP-A4M4 spare T cells in patients with advanced synovial sarcoma or myxoid or round cell liposarcoma. This study is now recruiting patients in the US and in Europe. At the CIDOS meeting last year, the final analysis of the phase 1 trial of the NY-ESO-1 specific T cell receptor patients with soft tissues with synovial sarcomas were presented. The study was divided in 3 parts, starting with screening of patients, followed by leukapheresis and manufacturing of expanding T cells, lymphodepletion, and T cell reinfusion. The patients were divided in 4 cohorts based on NY-ESO-1 expression and the lymphodepletion regimen. 45 patients were included in this study. As you can see in the waterfall plot diagram, the highest response rate was seen in cohort 1. This was the one with a high NY-ESO-1 expression and a high lymphodepletion with fludarabine and cyclophosphamide. The most common adverse events in this study were cytopenia, febrile neutropenia, which is a neutropenia accompanied by fever and infection, dyspnea, and a low natrium level. In conclusion, it can be stated that immune checkpoint inhibitors show efficacy in specific histologic soft tissue sarcoma subtypes, such as dedifferentiated liposarcomas, undifferentiated pleomorphic sarcomas, and alveolar soft part sarcomas. As the mode of action of immune checkpoint inhibitors in soft tissue sarcomas is still not clarified, the identification of biomarkers which predict treatment response seems essential. Furthermore, combination strategies such as combinations of checkpoint inhibitors with tyrosine kinase inhibitors, 2 checkpoint inhibitors or checkpoint inhibitors and chemotherapy show better response rates as compared to monotherapies with checkpoint inhibitors only. The complex therapeutic model of adaptive T cell transfer seems to work, at least in synovial sarcomas. However, the response duration has to be further evaluated. Furthermore, high costs and long hospitalization of this treatment has to be taken into account, and the long-term adverse events remain to be seen. Thank you very much for your attention, and I will be happy to take some questions.